my God, look what you just did to my car. Hello, lady. Car stopped ahead of you. Maybe if you'd stop cramming your face full of ice cream, you'd notice these things.
Is everybody here okay?
Yeah, I just got rear-ended, that's all.
Does anybody need an ambulance?
Well, I got a little whiplash, but I think I'm okay.
All right, we need to keep traffic flowing here, so go ahead and get back in your cars, and we'll get ready to move them to the shoulder.
All right. Holy crap, Johnson, come here. Did you see this mechanism of injury? Why isn't she C-spined yet? I want those batteries cut, and I want C-spines here now.
Okay, so as you can see in front of you, we have a little education on indications for spinal immobilization restriction. This is me, Dr. Wilson, speaking to you. Just as you saw the intro video that we did a couple weeks back, just to give you a taste of what's coming in the future when we're caring for our patients who may or may not require spinal immobilization. As you guys know, we've had a protocol in place for C-spine clearance for a extensive period of time, and now we're going to kind of go more in depth and look at some of the new things that are coming out of the education and the studies that have shown that we can do a little bit better with judiciously using our backboards, as well as finding the indications to immobilize a person's cervical spine in a hard collar. So as you can see, our main objective is to really give you, as the pre-hospital provider, a set of tools that you can use to select patients that would benefit from spinal immobilization. And when we talk about spinal immobilization, we're primarily talking about cervical spine immobilization. As we've seen in the teaser video that was sent out earlier, backboards have very little utilization for cervical spine for spinal immobilization as a whole. They're very useful for moving patients, but not useful for keeping patients immobile. So we'll get into this more as we get into the slides. But basically the objective is to give you guys and gals a set of tools that are objective, that have been tested in other studies to give you some credence to immobilize or not immobilize patients. So despite what many people believe is a level of illogic when it comes to immobilizing individuals, there is some logic to some of the things that we see. I mean, would you truly splint an arm of a patient with no complaints because of the mechanism? Say I was hitting the arm with a baseball bat, yet I have no complaints of arm discomfort. Would you automatically splint my arm? You know, a patient with a femur fracture, do you usually see them ambulating without any difficulty? And when we say effortlessly walking, it doesn't mean that they couldn't maybe bear weight, but would it really be effortless? Would it be like the individual who has a normal femur walking around a scene? So really, when we talk about things, you can split hairs sometimes to say, well, they're walking, that doesn't mean that they have a significant injury. Well, they could, I understand that. But at the same time, most individuals who have significant destruction of soft tissues, bone, nerve, they would have some significant symptomology that should be noted at that time. But there are individuals that are higher risk that may have mechanisms that seem to be very, very minor, such as an elderly patient who takes a fall. Very different than a healthy 20-year-old who takes a fall. And very different from a mechanism of a person falling from, say, 40 feet versus falling from a standing height. So yes, lots of things are factored in, and we're going to try and give you a better set of tools to really objectively look at these things versus subjective, hey, that patient I think needs to be collared because they've basically crashed their car, or that patient needs to be collared because they had a fall on their butt. and they're complaining of having some knee pain, and that could be a distracting injury. Or that patient needs to be backboarded and collared because I do that all the time. Not very good evidence-based rationales for doing things. So we're trying to give you a lot of evidence-based rationales for moving forward with immobilization. As many of you can see, backboards have a purpose. They have a purpose to move patients from one place to another. In 1966, as I mentioned in the previous video, Colonel Kossuth really put out that first description of the use of a backboard. The long spine board was used to move patients from the area of trauma to another area, so to get them from the vehicle to an ambulance, from the vehicle to a base station. So long boards have a use to pick up patients and move them from place to place. So the one thing that backboards always do is they cause pain. If you lay on a board for a long time, you're going to have pain, and we'll get into that in the future. So jumping from the 60s to the 80s, besides having fashion change and Duran Duran becoming popular, suddenly the Department of Transportation looked at the need to take all suspected spinal injuries and put them into collars and immobilize them on long spine boards. The collars came out of neurosurgical post-op patients who had work done on their cervical spines. So technically they had an injury that was induced by a surgeon to their spine, and not really injury. They had work done on the cervical spine, and to keep it stabilized, they would put them into a hard collar. So extrapolating that data, people said, hey, if somebody had an injury that was induced from, say, a fall or from a motor vehicle collision, wouldn't they benefit from having a collar placed on them? Now, as you can see, there's not a lot of clarity in this. It's all about patients with suspected spinal injuries. So who would be suspect? Is it always a patient that has a fall? Is it always a patient that has, neck pain? Is it always a patient who is elderly? Is it always a patient who's young? There's really no clarification on this. So basically, all patients required backboarding and spinal immobilization in a C-collar. So patients were being immobilized in 1984 on backboards and with C-collars with suspected trauma or suspected injuries. Now, most individuals, if they have a significant injury, will have some physical findings associated with that, whether they be neurologic, whether they be localized pain. So the science in this is, without symptoms and physical findings associated with spinal injury, no significant spinal injury exists. And that has to be, though, in appropriate patients, which is actually the key portion of the sentence. Some patients would not be appropriate to assess for spinal injury because you can't make that assessment. Remember, a patient who has altered sensorium, a patient who may have some distracting injury, the very young or the very old, those patients have a higher propensity to have injuries associated with occult injuries. So we have to have the appropriate patients that we can then make an assessment on. And once we have appropriate patients, we can then start using some of the tools that will be provided to properly assess their need for immobilization or not. So the other thing that we always hear is that you heard it from somebody who heard it from somebody else, that there was a patient you had out in the field who you were extricating from a vehicle, and they were initially moving their extremities, but as you got them out of the vehicle, they were then a quadriplegic. Now, this is one that you have to wrestle with sometimes, because that's always been the fear and the supposed rationale for individuals being collared and backboarded all the time with trauma. But let's think about this in a different fashion. That if the patient had, from the previous slide, no signs and symptoms associated with spinal cord injury, they don't have a spinal cord injury at that time. So if you move that person who doesn't have an injury, how are you going to injure them? Unless you actually pummel them like the Incredible Hulk. Now, if you have a patient, and this is once again looking at appropriateness of patients, who's complaining of having tingling in their arm, or they have neck pain, or they have weakness in the leg, and you inappropriately handle that individual, yes, the risk of worsening their injury is high. So hence, you have to do proper handling of the individual. Normal patient handling should not worsen an individual's injury. So the myth is actually this, that you as the provider caused the injury, when in fact the injury previously existed and may have worsened because of improper handling or lack of recognition that the patient needed spinal immobilization at that time. As I tried to point out in the video that was sent out earlier on, which I think I was actually blocking the skeleton spine, when you look at long backboards, and they're used to provide rigid spinal immobilization for patients, if you look at the curvature of your spine and you try to lay flat on a board, you'll see that there's not much immobilization that actually takes place to your spine, especially when you start rolling a patient. If you roll a patient and they've been immobilized at their head and you're trying to strap them to the board with your straps, if you turn them sideways, the spine actually will then shift. So in essence, there really is no immobilization that's taking place on the long backboard itself. So not much benefit. So what's the harm in putting people on backboards? Well, we're going to go into that a little bit as we kind of debunk some of these myths regarding spinal immobilization. And the hard thing about this is this has been going on, as you can see, since 1984 with the Department of Transportation stating that this has to be done. So we're trying to change the culture, and we realize as we've grown in our ability to collect data and really see what we do and how it actually affects patient outcomes, we can start debunking some of these myths that were instituted way back when EMS was in its infancy. So backboarding does cause pain. I mentioned that a couple of times. Really, if you don't believe the hype, then lay on a backboard for 10 minutes, immobilized, quote, immobilized, and come back to me and tell me how your back feels at that point. So the problem with pain being induced by the backboard is then it leads to unnecessary radiologic testing being performed and prolonged stays in the emergency department. So pain is one thing that the backboard causes. With that pain, over time, you start to have breakdown of skin, so cutaneous pressure ulcers can occur. And it doesn't take a very long time for those ulcers to actually start forming on individuals. You can start seeing some of the indentation and pressure when you've actually taken some of these patients, they've been on the backboard for 20 minutes or so. Breakdown of skin may take a longer period of time, but think about a very busy emergency department where it takes time for the patient to be cleared from the backboard, and the risk, or on those more fragile patients, the elderly, who may have a higher propensity to have breakdown of skin. It's been shown that individuals who are, once again, tied down to a backboard have reduced tidal volumes, and this can be very detrimental to patients who are having respiratory difficulty, or specifically for trauma patients who have thoracic trauma or abdominal trauma, specifically penetrating trauma. Individuals who are laying in a recumbent position also have risk of aspiration. This is even more so for those patients who have altered mental status if their airways are not protected. And patients that are actually laying on these boards and immobilized, quote, immobilized, also have evidence of increased intracranial pressure. So think of this with your patients who have head injuries. The concern is that their intracranial pressure increases and there's decreased cerebral blood flow. And of course, one of the most common injuries that can occur while on the job, of course, is from lifting and having injuries to your back. So carrying these individuals on these boards when they may be able to self-extricate and get themselves onto your cot helps to lower the risk of you developing injury while carrying these individuals from place to place. As I mentioned before, there's an increased mortality rate when used with penetrating trauma patients. No patient with penetrating trauma should be placed on a backboard. Remember all the deleterious effects that have occurred because of the decreasing tidal volumes, increasing risk of aspiration. So backboards for penetrating trauma, not useful. Even if you transected somebody's cord with a bullet, putting them on a backboard at that point is not going to prevent the spinal cord injury. The thing that would prevent the spinal cord injury is either being bulletproof or not being shot.
Much better. Alright, McMahon. I know this seems kind of silly, but why don't you go ahead and cut open that other car and cut that battery too? Just in case.
Oh, ma'am, if you go and lay down for me, I'm gonna put this brace down on your neck.
Look, my neck's just a little sore. I don't need any of that.
Ma'am, with all due respect, just look at that mechanism of injury.
Yeah, my car got hit.
Do you realize that tomorrow morning you could wake up and be a paraplegic? Is that what you want? Ma'am, come here. Does this hurt?
Ow, yes, that hurt. Ah!
Because that shouldn't hurt, ma'am. That should not hurt. Something could be wrong with your neck, okay? So you should probably let us take you to the hospital.
Okay, what do we got here? Holy, look at that mechanism of injury. Why isn't she C-spined yet?
Well, she just doesn't think that anything's wrong with her.
Well, did you even try the poke the spine test?
Twice. I guess she just doesn't understand the scientificness of that test.
Look, guys, I really feel like I'm okay. You're starting to scare me.
Ma'am, you should be scared. You see this? I didn't spend 22 weeks at EMT school for nothing.
Alright, go ahead and lay back and relax, and we'll get you wheeled on over to the ambulance, okay?
I think this is a little too serious to be hanging out in traffic for.
Yep, those rubberneckers sure make a mess of things.
So we're trying to make this into a very simple process so that you can use some objective measures to assess whether or not the patient requires spinal immobilization. So the first things you have to do are determine if neurological deficit exists. That can include a multitude of symptoms, whether it's tingling, whether it's pain, whether it's lack of movement. All those things definitely would have a higher index of suspicion of an individual having a spinal cord injury. Then secondary things are determine if the patient is a high-risk patient. And high-risk patients will have multiple definitions that we will actually have for you in the later coming slides. But if the patient is a low-risk patient, determine their reliability. Because once again, just because a patient's low risk doesn't mean they have no risk. And we have to be very cognizant of those low-risk patients that actually then become a higher liability risk because of other factors that may make it more likely that they have a spinal cord injury. And at that time, immobilization should be undertaken. Now, these seem to be pretty obvious signs and symptoms that would constitute having a high clinical suspicion that the individual has developed some form of neurologic insult. Now, complaining of motor function loss, loss of feeling, or even paresthesias like pins and needles, numbness and tingling, burning sensation in the extremities. All these things have to be kept in mind that these can be construed as neurologic deficits. I had a patient recently who was jumped on by her sister, was tackled because of an argument involving their mother. The patient was tackled and complained of having some neck stiffness, but also complained of having a sensation of burning in her shoulder and hand. Examining her in the emergency department, she had some discomfort along the cervical spinous processes as well as some paraspinal discomfort, so I immediately put her into a collar. The good thing is that her films did not demonstrate any fracture or any findings that would go along with significant spinal cord injury, and she was able to be discharged, but we have to have a high clinical suspicion at this point, and we must act upon the findings that we have. If we ignore the signs and symptoms of things, we will then have significant misses that will occur in the field. All of these patients have a high risk of cervical spine injury. Ejection from a vehicle, motorcycle crash greater than 20 miles per hour, auto versus pedestrian at greater than 20 miles per hour, rollover, axial loading to the head, of course, and falls from greater than 3 times the patient's height. Now, at the same time, these patients also are at high risk of having multiple other injuries. And at this time, a backboard's use may be somewhat beneficial to you as the provider to move the patient from place to place. But remember, the backboard's use for immobilizing the thoracic and lumbar spine has very limited benefit. But you may find benefit of splinting the individual's leg to the board if they have a femur fracture, or moving the patient when they have a hip fracture, or stabilizing an open book pelvic fracture. So remember, it's judicious use of the backboard, but the backboard itself is not immobilizing the thoracic or lumbar spine. I leave in provider judgment because that is where judicious use of the backboard has to come into play. You would find other uses for the board as a splint, but really remember, the board is not splinting the thoracic or lumbar spine. So, going back to that patient that I spoke about earlier on, though she had some high-risk criteria by having some neurologic symptomology she complained about, if she had no neurologic symptomology that she complained about but had point tenderness on palpation of her spine, which she did have, she would be a low-risk patient that I would consider collaring. And I did collar that patient. And she'd stay collared until we actually had objective films that showed no significant injury to the vertebrae that would lead to spinal cord injury. So keep in mind that patients that are low risk that have point tenderness, deformity, they actually likely will require some form of immobilization of their cervical spine. And the key word in this is spine tenderness. If I'm palpating the patient's left shoulder and they say, God, my shoulder's killing me, I wouldn't necessarily put them into a collar. If I'm palpating the patient's paraspinal muscles, which you've seen me probably do in the emergency department, and I clear cervical spines very rapidly, the likelihood of them having spinal cord injury is less. If I'm palpating directly on the spinous processes and they have tenderness, they need to be collared. Now here's where we throw some new variables into the game that can kind of make things a little dicey, but if you think about them, they somewhat follow a logical progression of things. We actually had a patient in the emergency department recently who had a significant spinal cord injury, yet it was missed by not only the field providers, but also the physician in the emergency department. The patient was complaining of shoulder pain after an episode of syncope. Now, you think, wow, that patient's actually a low-risk individual, but he actually fit some non-reliable criteria. The patient was a gentleman who was in his 80s. So an elderly patient has a higher propensity to have injury to bone because of demineralization that takes place over time. Osteodegenerative diseases are very common in these individuals. So at that point, a good examination of that patient may reveal that he'd have point tenderness on palpation along the cervical spine, which he did have on reevaluation when he was admitted to the floor. And they also found that he had neurologic deficit when he was admitted to the floor, unfortunately. So some of these low-risk patients who actually have non-reliability, such as they're not alert and oriented and calm, patients who are intoxicated, either with drugs or alcohol, have distracting injuries, such as a femur fracture, splenic injuries, unable to communicate adequately, either a language barrier or unable to communicate because of a deficit in brain function, individuals that are very young or at the extremes of age, so 65 isn't that extreme, it is considered old, unfortunately, or known osteodegenerative diseases. Think of Mr. Glass from Unbreakable. All these patients, as a precaution, because of their increased risk because of lack of reliability, are more likely to be collared. So these four things kind of sum it up. If you determine that the patient fails a neurologic exam or has neurologic complaints, they fall into a high-risk category, they're low risk but have spine pain or tenderness, or the patient is an unreliable low-risk patient, put them in a collar. Remember that backboards for spinal immobilization are really not useful. But as mentioned earlier on, if you have a patient that has other injuries, requires movement, ease of movement, backboards have their utility. So remember, the use of a backboard should be done in a very judicious manner. backboards should be looked at from the potential benefits versus the risks that were mentioned before. There may be some benefit towards backboarding a patient that you need to move from 20 feet in the woods to your cot, or a patient who has multiple injuries such as a femur fracture that needs immobilization, or an individual who has a hip fracture. There may be some benefit to the use of the backboard at that time, but remember, it's not beneficial for immobilization of the thoracic and lumbar spine. And this says it all. I mean, really, there should be a rare time that you're actually using the backboard for immobilization. So really, give me a damn good reason why you're doing it. And if I see you in the ER, I'm going to ask you, give me a damn good reason why you're doing it. So when we talk about the judicious use of backboards, remember, utilize the spine board or the short board or the CAD just to extract and move your patient. For trauma patients specifically, spine board should be utilized judiciously. If the patient has been ejected from a vehicle, those types of things, as we talked about before, other injuries can occur. So immobilizing, say, the individual's pelvic fracture, or immobilizing the femur against the board, or transporting and moving the hip fracture patient, the board may have its use at that time. Now, penetrating trauma has been talked about, and for most individuals with penetrating trauma, and really, in fact, penetrating trauma to the thoracic cage, there should be a contraindication toward the use of a backboard because of the untoward effects noted to tidal volumes and even intracranial pressure increasing for patients who have penetrating injuries to their head. So how do we get the patients away from the scene of injury if we're not using a backboard? Well, if the patient's able to ambulate on their own, at that point they likely have no evidence of thoracic or lumbar spinal injury. But even if they have a spinal cord injury to their cervical spine, they may actually be immobilizing their spine on their own by self-splinting. This is the typical presentation of an individual who has a neck injury. They will usually self-splint. And this is the individual protecting their own spine. There was a patient I had when I was a new attending, when I worked on the south side of Chicago, who presented a day after he had been involved in a motor vehicle collision, presented to the emergency department complaining of having neck pain and a tingling sensation in his arms bilaterally. And the patient came walking in like Fred Gwynn from the Munsters, unable to turn his head. He was basically holding his head with his hands on either side and would turn his whole body to look left and right. The amazing thing is this patient went home and attempted to go to sleep in his own bed and realized every time he tried to lay his head down, he started feeling more tingling in his arms. So he grabbed his head and sat himself up and slept sitting up in a chair. Walked into the emergency department, got his films performed after a collar was placed on him, and actually had a C3 injury. Needless to say, that was probably one of the luckiest men on the planet, and I told him to play the lottery afterwards. I don't know if he ever won the lottery, but he was very, very lucky. So remember that patients are going to typically self-splint. So at that point, putting a C-collar on them would be very, very intelligent. If a person's going to be C-collared, move the cot towards that individual. They shouldn't be walking towards the cot in any way. Very little movement and handling is going to be expected for these patients so that you don't cause them any harm. Because remember, it's a matter of the typical handling of a patient versus rough handling of an individual that could lead to worsening injury. So once again, proper handling of the patient is super, super, super important. Don't have the patient jog a block to assess their neurologic fitness. That would probably be looked at and frowned upon here in the system. Important things to remember: that patients with spinal injuries do have the potential for significant underlying injury and worsening condition. Now that might sound like I'm mixing my words from the beginning, saying that you don't typically take a patient out of a vehicle and suddenly they have paraplegia that occurs. What I'm saying is this, is that patients who have spinal injuries present with spinal injuries. So if we recognize these things from the very beginning and then immobilize those patients properly, the possibility for worsening morbidity or mortality becomes minimized. The patient who has no significant risk and has no neurologic findings or spine pain, they fall out of the categories of high risk, low risk, or being unreliable. These individuals do not have spinal cord injuries. But take all the patient's signs and symptoms seriously and cautiously. If a patient has a mechanism that you believe is very minimal, but they have spine tenderness, guess what? They fit the criteria as low risk, put them in a collar. You have justification to do so. If the patient is telling you that, God, I can't move my fingers very well, take that seriously. Put them in a collar. If the patient's telling you, my hands never felt this buzzing sensation before, after they've actually, tripped and fallen and hit their head, take it seriously. The worst thing is that we take someone's signs and symptoms and we minimize them and we miss the injury. And it has happened before. So, we're looking at a change in our practice. And backboards and their use should be very minimal for the majority of patients that we have and that we encounter in the field. It doesn't mean we're not treating cervical spine injuries or spine injuries in general. It's just that we're looking at what is the most effective and evidence-based way to treat those specific types of injuries. We'd like to continue to advance our practice. We'd like to be on the forefront and the cusp of things. So, it's going to be different. It's going to be new. Some people will have grumbling. Some people will be scared. But I'll walk with you hand in hand, and we're going to do this together. And we're going to still continue to be great. So yes, we'll be monitoring this, of course. Anytime there's a change in our practice, we need to make sure that we do quality controls on our new practice. Make sure that what we're doing is effective and correct. Make sure that we actually understand why, and we continue to field questions from you as the provider in the field and help you become more comfortable with the procedural change, as well as make you proficient in performing the procedure in the field. So we will be monitoring this. We'll have to collect data and make sure that what we're doing is correct and we're having good outcomes. So keep these things in mind. Whether or not a backboard is used, attention to spinal precautions among at-risk patients is paramount. These include application of a cervical collar, adequate security to a stretcher, minimal movement transfers, and maintenance of inline stabilization during any necessary movement and transfers. This is the future that we're looking at. And right now, we have not changed our practice as of yet. So this is not a green light for you to go out and suddenly change what you do. Continue to follow our protocols as they are written. We have a cervical spine clearance protocol that should be used in the interim. But we will be coming out and moving forward with this once we actually have education completed and questions answered. But right now, don't change your practice. But as you see patients, think about these principles and think about how you would use them.
Dispatch 20 copies. Air ambulance landing on the freeway, and all traffic is already stopped.
MRE Air 1 on approach. Whoa, look at that mechanism of injury. I hope they C-spined her.
A helicopter, really? How much is this gonna cost?
Let me ask you this. Wouldn't you say that your life is worth a mere $17,000?
17,000?
Shh. No thanks is necessary, ma'am. Just doing my job. Well, at least I won't have to drive very far.
So what's next? Next, we need to hear from you as the providers. We need to get your questions answered. So compile your questions together with your colleagues. They'll be forwarded to us, and we're going to come back with another wonderful video with some answers to those questions. And then we're going to step into the future. And stepping into the future is a wonderful thing, and it's going to be very exciting. So get your questions together, send them to us. We'll get back to you, and we'll see you out there in the field. Keep doing great work, guys.